Hello, I'm DJ Yao. This is my physical assessment project for Nursing 305, Physical Assessment with Dr. Oden. This is my patient, my volunteer, my wife, Jennifer.
Hi.
And I'm going to be performing my head-to-toe assessment on her. So first what we want to do is we want to start by moving in a head-to-toe fashion, starting with the head, and of course starting with inspection. So first what I want to do is I want to look at my patient, inspecting first of all the hair, whether it's coarse, rough, whether it's fine or silky, as sometimes those can indicate thyroid problems. Next I want to look at how the patient holds her head. It should be still and upright. There should be no bobbing or jerking. Jerking or tremors could indicate Parkinson's, of course, in an older, usually individual. Also I want to look at, as I'm speaking to the patient, is she tilting her head towards me? That could indicate hearing loss. And also if she's squinting as I'm talking to her, showing her something, that could indicate vision loss. Next, what I want to look at is the shape of my patient's face. Is it round? Is it moon-shaped? That could link patients to Cushing's. It also could be from steroid use. Also, in the older individual, it's normal to have kind of a sunken face. But in individuals that are, say, middle-aged, that could be indicative of cancer or metastatic disease. Also, what I want to look at are unusual features, such as, for example, a rash or a lesion. For example, a butterfly rash across the bridge of the face, bridge of the nose and the cheek, which is common in patients with lupus. Also, in female patients, I want to look for excess facial hair, as that can be known as hirsutism, which is also a sign of thyroid disease. Next, what I want to do is I want to have my patient to show me some facial expressions as I'm going to do my cranial nerves as I move through the head-to-toe assessment. So what I'm going to ask her to do is to wrinkle her forehead, and then to squint her eyes tight as she can. Good. And then to smile and frown and puff out her cheeks. And that indicates that cranial nerve 7 is intact. Next, what I want to look at also, as the patient smiles, I want to look and see if that's symmetrical, not just the whole face is symmetrical, but as she smiles, is it symmetrical? For example, if the entire side of the face is asymmetrical, for example, drooping on one side, then that can be linked to the facial nerve. For example, patients with Bell's palsy or patients that have had a stroke and left them with some deficit. Also, if it's just the mouth that maybe droops, then that may be the trigeminal nerve. So next what I want to do is I want to test my patient's cranial nerve 5. I'm going to do that by doing soft touch or light touch. So what I'm going to do is I'm going to have the patient to close her eyes, and I'm going to touch 3 different areas of her face, and she's going to tell me what areas that I'm touching. So I'm going to start, I'm not going to rub, I'm just going to touch those areas.
Chin, forehead, cheek, forehead, chin, cheek.
So that she identified them correctly. So patient's cranial nerve 5 is intact. So moving down, I want to look at the neck. Hold your head up straight for me. I want to look at the neck. For example, some patients have webbing or excess skin in their neck. That can be linked to chromosomal abnormalities. Also, what I want the patient to do is to flex your neck, bend it forward for me, and extend it back. And if you can, move it side to side. And then maybe even around in a circle. Range of motion. So the patient should be able to move with no pain or stiffness, for example, nuchal rigidity, which can indicate meningeal inflammation, such as patients who have meningitis. So next what I want to do is I want to palpate the lymph nodes starting in the head. So I'm going to start at the back of the head, at the base of the skull here, with occipital nodes. And then I want to move it around to the ears to the pre- and post-auricular nodes. And then I'm going to move underneath the chin to the submental and along the jawbone to the submandibular, and then moving down along the clavicle to the clavicular, which work along the clavicle bone there. And then I'm going to lift her arm here, and I'm going to check for axillary nodes. And then if you'll lay back for me. In the hospital setting, what we would do would be more skin-to-skin contact, but for the privacy of my patient, inguinal nodes here, and we would check for those as well. Let me sit back up. So what we're looking for, generally those nodes, for most of the time, are not able to be palpated. If they were, for example, the submental or the submandibular, that could be indicative of, for example, a sinus infection or allergies. What we really want to look for are nodes that are fixed or shoddy. For example, feel like BBs under the skin. Those that are matted in particular or feel like they're stuck together can sometimes indicate metastatic disease, cancer. As far as infection is concerned, we want to look for edema or red streaks around those nodes. So next what we'll do is we'll move on to assessment of the eyes. So what I'm going to do is I'm going to have you turn just a little bit. And I have a Snellen chart. Approximately 20 feet away is what we would really want to place it for the patient. So what I'll ask you to do is to read the smallest line that you can read.
D, E, F, P, O, T, E, C.
And actually what I'm going to get you to do is to cover up and do it one eye at a time as well.
D, E, F, P, O, T, E, C.
Okay, and then to the other eye.
D, E, F, P, O, T, E, C.
Okay, so that's using the Snellen chart to assess far vision, visual acuity. And what we do is we record which line the patient read, and of course at 20 feet, for example, 20/20 vision. So then next what we do is to assess near vision, we use a Rosenbaum chart. So I'm going to hold it out here and you're going to cover up one eye at a time. And once again, this test for near vision, approximately 14 inches from the face, and you tell me which line, the smallest line you can read.
6, 3, 9, 2, 5.
Okay, and the other eye?
6, 3, 9, 2, 5.
Okay, and so that's the Rosenbaum. So next what I want to do is, hang on to that, I'm going to do the confrontation test, which is going to tell us about peripheral vision of the patient. So I ask you to turn towards me, okay, and we're going to cover up, she's going to cover up, for example, the left eye first, and I'm going to cover up the opposite eye, which is directly across from her, and I'm going to bring my fingers into our field of gaze. She's going to stare at me, and she's going to let me know when she can see the tips of my fingers, and I'm going to perform it in 3 or 4 different areas, the nasal, the temporal, and then inferiorly, and she's going to let me know. And we should be able to see it at the same time, assuming that my peripheral vision is intact as well. So,
Yeah.
okay, and then a little higher,
Yeah.
and then a little lower.
Yeah.
Okay, all right, and then we're going to change, obviously you would change to the other eye. I'm not going to do that for the sake of you being able to see it. So, her peripheral vision is then intact, and it corresponds. So next what I want to do is I want to inspect the eyelids, the eyebrows in particular. I'm going to ask the patient first of all, especially if it's a female, do you pluck or trim your eyebrows? Coarse, rough hair can indicate thyroid problems. And then moving on down to the eyelid, if you'll close your eyes for me, I'm going to look along and look for any swelling, any redness along her eyelid. Also in the orbital area, the periorbital area, is there any edema? This can indicate allergy, thyroid disease, and in younger patients it can indicate renal disease as well. Another thing that we want to look for when we're looking at eyelids is xanthelasma, which are slightly raised, yellow-tinted lesions. And what that indicates is an abnormality of lipid metabolism. So next what I'll do is I want to test the patient's cranial nerves 3, 4, and 6, which is her ability to follow my pen. So hold your head still, and I want you to just follow my pen. In doing this, she's able to move her eyes and not her head. and I am able to check her fields of gaze. Now when I go to the side, as far as I can go, we'll notice that the patient's eyes tremor just a little bit. This is nystagmus, and this is a normal finding. So moving back to the eyelids, some abnormalities that we might find are ptosis, which is a drooping of the eyelid. That's related to muscle weakness and related to cranial nerve 3. As I look at the patient, I'm going to pull down just a little bit. I can look at the patient's eyelid. If it rolls in towards the globe, that is known as entropion, and then rolls away from the globe, that is extropion. So next we'll move into the conjunctiva. I'm going to pull down. I'm going to ask you to look up, and then I'm going to pull down on your eye. So a normal conjunctiva is clear, pinkish, a little bit of vasculature to it. You want to inspect it for erythema or bright. If it's bright red, that could indicate some hemorrhage. Also, some purulence, some drainage there could indicate conjunctivitis. So next what I want to do is I want to look at the patient's cornea. So once again, I'm going to ask you to look up just a little bit. I'm going to bring the light in from the side. I'm going to look at the angle that it comes across the eye. I'm going to look at the cornea of the eye, not blinding you for too long, and look for abrasions or ulcers in the cornea. Also, what I'll do at this time is I'll check the patient's corneal sensitivity. So again, I'm going to ask you to look up. I'm going to pull your eyelid down. And a normal response is that the patient blinks. Also, what I can do then as well is to bring the light in from the side and look at the pupils. The pupils should constrict, and also, as I bring the pen into the patient, the pupils should constrict as well, and they do. And the pupils are equal, round, and reactive to light and accommodation. So next what I want to do is I want you to close your eyes for me again, and I want to palpate the lacrimal gland, which is at the inner canthus, the inner corner of the eye. Can be slightly enlarged. What you might notice is that the patient complains of dry eyes if it's enlarged, and that's because of inadequate tear formation because of that lacrimal gland being enlarged. So next what I'll do is I'll get my ophthalmoscope, and if you'll turn towards me right here. So what I want to do with the ophthalmoscope is I'm going to bring it from away from the patient towards the patient, looking in and adjusting it. Excuse me. I'm going to go the same eye as the patient. So I'm going to look at her left eye with my left eye, bringing it in and adjusting it. And what I'm going to notice is there's a red reflex, and that indicates illumination of the retina. Now once I've visualized the retina, I can then move in further, making sure that I keep it adjusted. And I'm going to visualize the fundus and the optic disc as well. Any opacity, or excuse me, anything hindering or blocking the retina would appear as a dark, dense material. Opacity such as cataracts or even a hemorrhage would cause that. As far as visualizing the fundus and the optic disc, you can notice some drusen bodies in around there which are yellowish, and they increase over time, so we want to kind of make note of those. Visualizing the optic disc, the vasculature of the eye branches away from the optic disc, so we are able to find it a little easier. Moving away from the eyes, I'm going to inspect the ears. And first what I want to do is I want to face the patient again, and I want to kind of draw a line from the outer canthus of the eye to the top of the earlobe. To the top of the ear. Ears that are low set can indicate chromosomal abnormalities, such as Down syndrome, for example. So I want to look at the outer portion of the ear. You turn your head back this way. Outer portion of the ear, and we're going to notice the helix and the antehelix and the lobule and the tragus, just to identify our landmarks. And next I'm going to get my otoscope and work to visualize the middle ear. So what I'm going to do is I'm going to pull the auricle. The best way is to pull the auricle up and back, and then resting the otoscope on the canal there and moving in, I'm able to visualize the tympanic membrane. Visualizing the tympanic membrane, it should be bluish gray in color. What you'll notice as you visualize it is that there's a light reflex, a cone of light reflex there, and that tells you that it's shaped correctly, which is convex. The reflex is caused by the shape. If it were, for example, it should be concave. If it were convex, for example, it would be bulging, indicate fluid or pressure behind the ear. It should be intact. The tympanic membrane should. No perforation, no holes there. Also, in visualizing the tympanic membrane, there's the pars flaccida, which is the upper portion of the tympanic membrane, and then along the majority of the tympanic membrane is the pars tensa. So moving from there, I want to assess my patient's hearing, and in assessing the hearing, we're assessing cranial nerve 8. So what I'm going to do is I'm going to ask you to put your finger in your other ear. I'm going to stand behind her and I'm going to whisper something. She's going to repeat what I say.
The weather is cold.
The weather is cold. So that's correct. So we know that the patient's hearing and cranial nerve 8 are intact. What you could also do would be the Weber test using a tuning fork. You would strike the tuning fork, place it on the top of the head. The patient would then tell you if sound was lateralized or stronger in one side or the other. And that could indicate, if it were, could indicate hearing loss in one ear or the other. Also, what you can do is the Wren test, which is with a tuning fork as well. Strike it, place it behind the ear, and when the patient can no longer hear it, she would let you know she can no longer hear it. You move it to the side, and when she can no longer hear it from there, the ratio is air conduction should be 2 times longer than bone conduction. If it's not, then we know the patient probably has some hearing loss. Also, what I want to do now is move on from the ear, and we're going to look at the patient's nose, moving on with around the face and the head. I want to look and see if there's any swelling, which could indicate some allergies, some bruising, if the patient's had a nasal fracture in the past, if there's a deviated septum. And also what I want to do at this time is test the patient's sense of smell, which is cranial nerve 1. So I'm going to introduce 2 smells to the patient. First one, and she's going to identify those.
Vanilla.
Vanilla, that's correct. And then another smell
Alcohol.
is alcohol, that's correct as well. So we know that the patient's cranial nerve 1 is intact. So next what I want to do is I want to inspect the patient's mouth. So I'm going to ask you to open your mouth really wide for me. And I'm going to use a tongue depressor to press down the patient's tongue and check. And what I want to look for is I want to look back into the throat, back in the tonsil area, and see if there's any swelling, any purulent drainage. Of course, if the patient's had their tonsils out, as I know Jennifer has, then you won't be able to identify those. We also want to look at the tongue and inspect the tongue, if there's any plaque or lesions along the tongue. Also, what I can do is I can slide it along the back, and as you can see, it stimulates the gag reflex, which is patient's cranial nerve 9 and 10. So what I'll ask you to do also is to stick your tongue out and then move it to one side and then the other. And that tells us that the patient's cranial nerve 12 is intact. So what I'll do now is I'll move to the assessment of the chest and lungs. So first, of course, what you want to do is inspect the patient. You want to look at the patient for symmetry. Are they kind of big-chested? Are they barrel-chested? And then you want to identify your landmarks. And looking at the anterior view of the patient, the suprasternal notch is at the top of the sternum here, just below the trachea. And then just below that is the angle of Louis. And in identifying the angle of Louis makes it easier for us to not only assess the chest, but later the cardiac system, as we're able to identify the intercostal spaces down from there. The costal angle, if you sit up real straight for me. The costal angle is below the xiphoid process, which is here, and then the angle that the ribs create coming in, then we have the costal angle here. And then also what we want to do is we want to identify our imaginary lines on the patient. So from the side, you can see that straight down will be the mid-axillary line. And then we would have straight down across the anterior portion, is the mid-sternal line. And in between there, through the middle of the clavicle would be the mid-clavicular line. And then through here would be the anterior axillary line. And if you'll turn all the way around for me. Then we have the vertebral line. And then along through here is the scapular line. Also, what we can do at this point, if you lean forward just a little bit, we can notify some landmarks on the back. C7, the bony prominence on the back of the neck at the beginning of the spine here, the beginning of the shoulders per se here, is C7, and then you can count from there, T1, so far. Also, you can assess the patient for any spinal abnormalities at this point. Jennifer actually has scoliosis, so we can see that the spine does have a curved angle to it. And also, as you can tell if I place my hands here, her scapula one is higher than the other. So we can identify deformities of the chest at this point as well. So first, what you want to do, also you can turn back around. While you're inspecting the patient, you want to note not only the rate of their breathing, but you also want to look for clues of distress, for example, such as retractions, intersternal retractions, any difficulty, any auditory breath sounds before you even put your stethoscope on. So next what I want to do is I want to auscultate the patient's breath sounds. So I'm going to ask her first to lay back and I'm going to listen to the interior breath sounds. So what I want the patient to do is breathe like normal but take good deep breaths for me so I'm able to hear them. Good deep breaths in. Good. Good. Okay. Okay. And if you'll sit up for me. And we want to do the same thing. Actually, turn all the way around again. And we want to do the same thing on the posterior. Good deep breaths. Okay. Actually, what I want you to do is to take your arms and kind of fold them across the front and lean forward just a little bit. What that does is help to expand the lung fields. And we'll do that again. Breathe. Okay. 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 And looking at the posterior view, breath sounds that are normal, for example, the lower pitch sounds that you normally hear are vesicular, and they're generally across healthy lung tissue. In the back, what you may hear are bronchovesicular, which are right over the bronchi, right here on the back portion. Then turn it around. Once again, normal are vesicular over the healthy lung fields, and then you would have bronchovesicular directly in the middle. Those are the medium pitched, medium intensity sounds, and then the higher pitch, higher intensity would be found up here over the trachea, the bronchial sounds. Adventitious sounds and adventitious sounds that you may identify, for example, would be crackles, which can range from fine to coarse. Fine crackles sound like crackles, like Crackle Pop cereal, and then all the way to coarse, which can sound almost like a bubbling sound. Those sounds are not cleared by a cough, which makes them easier to identify from rhonchi. Rhonchi sound like coarse crackles, but they're more of a snoring sound, and they may clear with cough, and you can actually sometimes hear them higher up. Also, some sounds that you may hear are wheezing, which is a musical or squeaking sounds that sometimes you'll hear with, for example, asthma really high up with obstruction, also COPD. And then finally a pleural friction rub, which is just a dry, rubbing, grating sound. So next what I want to do is I want to palpate the patient for tactile fremitus. So what I'm going to do is I'm going to place my hands on either side, and I'm going to ask the patient to repeat 99.
99.
And I'm going to move my way up.
99.
And up again. Go ahead.
99.
Okay. And what that tells us is there's decreased tactile fremitus over areas of thickening or effusion, and there can be increased tactile firmness over, for example, fluid or a mass. So next what I want to do is I want to palpate the trachea. And so what I'm going to do is ask you to lift your head up just a little bit. I'm going to place my hand on either side here. I'm going to ask you to breathe deep breaths. And what we could see is we could see a pull to one side or the other, which could indicate a pneumothorax or some kind of blockage on one side or the other, is what that could tell us. Next, I want to move to percussion. So I'm going to ask you to turn all the way around again. And what I'm going to do is I'm going to do indirect percussion. So I'm going to place my non-dominant hand on the patient. And I'm going to strike with my dominant hand, with the motion coming from the wrist. I'm going to strike my middle finger. And I'm going to move across and then down. And the sounds that would be normal were higher up across the bone and muscle tissue, you're going to hear a flat sound. Now over normal, healthy lung tissue, you're going to hear resonance. Over the liver and then around on the front, on the cardiac where the heart sits, the cardiac would also be dull. And then over the stomach, you would hear tympany. So next I'm going to move into my cardiac assessment. So you want to turn back around. And I'm going to look at the patient. Look pretty much a lot of the times at the periphery you can tell. Also, this goes back to the respiratory assessment. Is there clubbing in the fingers? Is there cyanosis, indicating that we're not getting good blood flow, we're not getting good oxygenation to the periphery. That can also tell us about the cardiac as well. Are we seeing peripheral cyanosis? You know, if we're seeing central cyanosis, then we better do something. It's an urgent issue. Also, we're going to look at the legs later on. Especially, we can look at them now, but in the musculoskeletal assessment, we're going to look at the legs and we're going to see, you know, are we having no hair? Is the leg shiny? We're going to look for arterial insufficiency or venous insufficiency when the blood's not moving back as well. For example, a venous ulcer, darkened legs there. So what I want to do is I want to have you lay back. At a 45-degree angle is best to assess the cardiac system. And I want to palpate for the apex of the heart. I'm going to do that with this hand. And I'm going to find where the strongest pulse, where I can feel it the best, and that is usually at the apex of the heart. And also what I want to do is I want to assess the carotid pulse on the opposite side. And feel the difference between. Carotid pulse correlates with S1 of the cardiac cycle. So next what I want to do is I want to auscultate the heart sounds. And I'm going to move in order from aortic to pulmonic to Erb's point to tricuspid to mitral. So I'm going to start with aortic, which is at the second intercostal space on the right sternal border. And then to the pulmonic, which is at the second intercostal space on the left sternal border, and move just down from that is Erb's point. And just down from that is the tricuspid. And then at the apex of the heart, the mitral valve is best heard there. S2 is best heard at the pulmonic valve, which is the second intercostal space on the left sternal border. And that correlates with diastole, which is the closure of the semilunar valves. And then at the apex of the heart, we best hear the mitral valve, and also S1, the beginning of S1, which correlates with the closure of the AV valves. Something that you may also hear would be an S3 or an S4. Both occur during diastole. S3 occurs early during diastole, S4 occurs late during diastole, and those may be described as a gallop. So that concludes the cardiac assessment. Actually, sorry, I want to move back. I want to assess pulses, starting, we've already assessed carotid, and I want to move down to brachial, and then to radial, and then femoral, popliteal, which is behind the knee, and then I can do dorsalis pedis. And so we know we have good pulses, good flow through the body. I'm going to sit up for me. Next, we're going to move on to assessment of the musculoskeletal system, and we're going to work the same way in a head-to-toe fashion. So what we want to start with is we want to start with the first joint, the TMJ joint. And so what I want you to do is to open your mouth really wide and close it and move it from side to side, your bottom jaw. And then I want you to poke your chin out, your bottom jaw, poke your chin out, and then pull it back in. And so we know we have good range of motion in the TMJ joint. Now we've already assessed the cervical range of motion, but we'll do it again. We want to flex it forward. I'm going to extend it back, extend it all the way back, hyperextension, and then from side to side. And then you can move it around in a circle. We know we have good range of motion in the cervical joint. Excuse me. Next, we want to move down. We can move down the spine to the thoracic and lumbar. And what you can have the patient do is to bend there. We know we've got a little bit of movement. It's a little more stiff there, and particularly in Jennifer, who has scoliosis and has had surgery. And also we could ask our patient to twist from side to side, and that would tell us what kind of movement we've got in the thoracic vertebra. Moving to the shoulder. We want to do good range of motion. We do passive range of motion. We can go all the way around. We can lift up, lift down. Moving down to the elbow, we can flex and extend, pronate, and supinate. And as you flex, what we can do is I want you to pull back away from me. Right, so we know we have good strength, motor strength there as well. Same thing in the wrist, pronation, supination, and then flexion, 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 and extension. So we know we have good movement in those joints. And if you want to lay back for me, and we're going to do on this leg, we're going to do your hip. You want to lay back. Right? And so we lift your leg up for me. Good. And then we can move out to the side with abduction, adduction. We can internally rotate, and we can externally rotate. Same thing in the knee. We can do flexion up towards the abdomen and extension, and we can even hyperextend just a little bit there. And then we move down to the ankle. We can plantar flex, which is out, dorsal flex, which is in, and we have good circular range of motion as well. You want to sit up on me? Right, so then we move on. We've already tested the cranial nerves, but I'll review them. I'll move through them in my head-to-toe assessment. Cranial nerve 1, we tested for smell. Cranial nerve 2, we tested with the visual acuity with the Snellen chart and the Rosenbaum chart. Cranial nerves 3, 4, and 6, we tested with the fields of gaze. Cranial nerve 5, we tested with symmetry of the face when the patient smiles, and also with sensitivity with light touch. Cranial nerve 8, we tested with the whisper test. You can also test with the Weaver and the Reid test. Cranial nerves 9 and 10, we tested with the patient's gag reflex and also their ability to swallow. Cranial nerve 11 with range of motion of the head and the cervical spine. And then cranial nerve 12, she was able to stick her tongue out and move it from one side to the other. So next what we'll do is we'll test the patient's fine motor skills. So what I want you to do is I want you to pat with the palm of your hand and then pat with the back of your hand and kind of increase your speed back and forth. Good. Okay, and then what I want you to do, I want you to turn towards me. And I want you to touch your finger to your nose and then touch it to my finger there. And go back and forward and then do it with the other finger as well. Okay, so the patient's fine motor skills are intact. Next, we'll check the patient's cerebellar function. So I want you to stand up for me. I'm just going to move this table back just a little bit. Move back just a little bit towards me. And stand and close your eyes. And what we notice in the patient is there is some sway, and that's normal. That's a positive Romberg, and that is normal for the patient to sway just a little bit. You can open your eyes. Okay, next I want you to step back away from me. And then what you can't see, but what I'll have her do is to walk heel to toe. So put one foot right in front of the other, heel to toe. Put your next foot in front. There you go. Walk towards me. Okay, then turn around and go back. So the patient can walk heel to toe. Next, what I'll have you to do is come back towards me just a little bit and stand on one foot. So the patient should be able to do this. This may be a little bit difficult, but she is able to do that. Next, what I want you to do is back up just a little bit. And I want you to walk towards me on your toes. Right, on your toes. And then stop. And if you want to turn and walk the other way, walk on your heels for me. So we know that the patient's cerebellar function is intact. So next what we'll do is we'll test reflexes. So if you want to sit back down for me. So first we're going to start and work our way down, of course. We're going to test the biceps reflex. So we do that by holding the arm out, just slightly bent. We find the biceps muscle here, and then right in here. And we see that there's a reflex there. Next we do triceps. We hold it out to the side. I'm going to stand back here so you can see it. We find the triceps. We notice there's a reflex, there's slight movement there. Next we check brachioradial. Hold the patient's arm out. We strike in here. And we notice that there's a reflex there as well. Next what I want you to do is, actually let's just check your patellar reflex. As you can see, strike here. And we have good patellar reflex on both sides. You can lay back for me. Okay. Let me finish this. Lay back. Just lay back. Okay. And so what we want to do, we want to test the abdominal reflex. And what we do is we can start at the umbilicus and work our way upward. What we notice is there's, you can't see of course, but there's slight movement there towards. Okay. Then we want to move to the Achilles reflex. I'm going to hold it just like that. I'm going to hold it where, let's change arms, where you can see it. Notice that there's slight movement there as well. And then what I want to check is check for a plantar reflex. And what I do is take a blade or the butt of the reflex hammer, work it across, and there should be a fanning of the toes as you can see there. So this concludes my physical assessment. Thank you.